Okay, so without further ado, I am going to welcome you all to this webinar this evening, Approaches to Mental Health and Substance Use for Healthcare Providers Supporting Indigenous People and Communities During COVID-19. I'm Irma Jean Baynock, and I'm one of the directors at the Registered Nurses Association of Ontario. And on behalf of Doris Grinspan and all of the members really of our association, I'm really pleased to welcome you here tonight to this webinar, which we are really sharing with you in partnership with Sioux Lookout First Nations Health Authority, with the Chiefs of Ontario, with the Nishnawbe Aski Nation, and the Indigenous Services Canada. So we have a large and very important partnership, and we're just delighted to be here tonight to share this important information with you that we really hope will help in your interactions and care with those you serve. So I am going to now turn things over to Mayor May Cat, who will do the land acknowledgements.
Good evening, everyone. It's an honor to make the land acknowledgement tonight. I recognize that our work and the work of our members takes place on traditional Indigenous territories across Ontario. We also wish to acknowledge that the office of the RNAO is located on the traditional Indigenous territory of the Huron-Wendat, Haudenosaunee, and most recently, the territory of the Mississaugas of the Credit. We also recognize that the participants on today's webinar are located in other traditional lands across Ontario. Today, the meeting place is still the home to many First Nations, Inuit, and Métis people from across Turtle Island. And we are grateful to have the opportunity to work on this territory. By personally making a land acknowledgement, you are taking part in an act of reconciliation, honoring the land and Indigenous heritage, which dates back over 1,000 years.
Thank you, Meg. Hi, good evening, everyone. My name is Sabrina Morelli. I'm a program manager of the Mental Health and Addiction Initiative and the Supporting Indigenous Health Initiative at the RNAO. It is my absolute pleasure and privilege to be with you here today. And I'd like to now introduce our panelists for today's presentation. So May Cat, who gave us the beautiful land acknowledgement, is a primary healthcare nurse practitioner. She holds a degree and Master's of Education in the curriculum specialty, has received an honorary doctorate in law from Trent University. She coordinates a mobile treatment team that provides opiate agonist treatment with Suboxone in rural and remote First Nations communities, and has led the creation and implementation of a Suboxone program in a local First Nation high school. She is a member of NAN, NAN's COVID task team, advising the leadership on pandemic planning responses, and she's also on the NAN Health Transformation Advisory Council. And in her free time, she enjoys golfing. Our second speaker is Dr. Sharon Cerrone. Dr. Cerrone is a family physician with a certification of added competence in addiction medicine from the College of Family Medicine of Canada. She works in Sioux Lookout region in the communities of Wigamau and KI First Nations. She participates in the regional mental health and addiction clinical policy and education initiatives. And she loves going fishing when she's up north. And our final speaker is Dr. Lindsay Hancock. Dr. Hancock is a family physician who has spent the last 11 years working in Sioux Lookout and acting as a community physician for Deer Lake First Nation. She has special interests in Indigenous health, mental health, and addictions and transgender health. Just because we're saying something personal about everyone, she has a beautiful dog named Sadie, who hopefully will make a little bit of an appearance today.
So before Sabrina moves ahead with the housekeeping notes, I do want to take the opportunity to thank everyone. We normally leave that at the end. I think it's important to do it right at the beginning And I want to make sure that we acknowledge and thank Matt, Sharon, or I mean Kay, May. I'm getting your name all mixed up. May, Sharon, and Lindsay, and also Sabrina and Tanya, who all of whom have worked tirelessly to make sure that they present really something that will be very valuable to you. So thank you all very much for your work in this. Okay, thank you, Sabrina.
Thanks, Erin Jane. Just a few housekeeping items before we start today's presentation. In the chat box, you can type any comments or questions you have during the presentation. I'll be monitoring them, and we have reserved some time, about maybe 20 to 30 minutes at the end of today's session for a Q&A period. Questions that we do not actually get to, we will take back as a panel and provide a written response to those. We will be recording and archiving this webinar for future viewing, and a link will be sent out with our evaluation survey. A full bio and evaluation link will also be forwarded post-webinar. And before we get the webinar started, we just have a poll question, because there'll be poll questions intermittently as we go throughout today. So what we would like to know right now is how many people are watching this webinar with you right now? So poll open.
We're just at 80% respondent rate, so just a couple more seconds. And I'm ending the poll and I'm sharing the results.
Fantastic. So majority of the participants are watching this by themselves, but there are a couple that are with other people, which is wonderful as well. So again, if you have any questions for our panelists as we go throughout the presentation, please just do record them in the chat box. We will reserve a Q&A session at the end, and there will be interactive polls as we move throughout the presentation. So without further ado, let me hand it over to Maykat and Dr. Cerrone to take us through today's presentation. Thank you.
I'm just going to declare that I cannot get to my arrow to move the slides.
Give me one second.
Tanya.
Okay, give me 1 second, Sharon, and I will. Do you want to give it a try now?
I'm sorry, the toolbar won't go down. I can't move it.
Okay, give me one second.
Maybe that worked. Maybe I did it with my arrows. My apologies, everybody.
Do you want to try using the arrow on your screen, or try it now? The toolbar seemed to have gone down.
No, I'm sorry.
No, okay. So I'll go ahead and advance your slides if that's okay.
Thank you. Thank you.
Just give me 1 second. I'm just going to take control back. Okay, go ahead.
So in terms of the objectives of this webinar, this is a large a topic with much breadth, much to discuss. 90 minutes wouldn't do justice to all of this, but to start with a baseline of where some of our experiences are in terms of understanding mental health and substance use issues in some of the communities where we work, whether urban, remote, or rural. And then what's perhaps some of the trends that are happening during this COVID-19 era. We specifically wanted to bring to your attention some tools that have been rolled out during the COVID-19 era around withdrawal management. And Lindsay Hancock will be speaking to that. And then also some aspects of what's of critical importance in many of our communities, and that's issues to do with opioid overdoses.
So the overview slide talks about, again, some of the mental health and substance use issues that are being faced by Indigenous peoples and communities. We're noticing, of course, no matter where you live in the community or in urban hubs, there's still a number of issues that impact our families and communities who live in remote and rural areas. Just the statistics, if you work in our areas, you know that suicides in First Nations is probably entering high numbers for about 3 decades now. It's twice the national average. Our youth and our young people in the NAN territory, we've lost over 6 600 young people to suicide between the ages of 15 to 24. That rate is 5 to 6 times higher than non-Indigenous youth in Canada. There's significant post-traumatic stress disorder. And I think if you look at PTSD, you know, that's the symptom of years and decades and over a century, I think, of historical trauma, the intergenerational trauma, as well as what we would call soul wounds, that just are wounds that never go away and permeate your life as well as that of your family. We're also going to talk about some of the adverse childhood events. It's looking at scores higher than the general population, knowing that our little people are impacted by mostly the social determinants of health, the poverty, the crowded housing, and certainly from the trauma that they've witnessed within their family and community. As providers, we diagnose and we treat high rates of major mood disorders, depression, anxiety, as well as psychosis. I think in the northwest of Ontario, where we work, the incidence of adolescent psychosis has been on the increase for at least the last 5 or 6 years. There's a number of co-occurring developmental disorders as well that can be attributed to alcohol and substance use disorders.
This slide is to give you a pictorial or an image or a metaphor, if you wish, to get a sense of what we're seeing when we see patients in the different settings where we work. There's many people on the call here. Some are from urban settings, some are from remote nursing stations, some are from the north, some are from the south. So we all work in different settings. And when we see patients or families come into the settings where we work with mental health and addiction issues, either or sometimes both overlapping, there's only a certain amount of what we're seeing in front of us, or what we're experiencing in our interactions with the patients that we're caring for, or the clients in our clinics, that we're seeing above the waterline. Much of what's going on is below the waterline. And this gives you an image of how immense that is below the waterline. The suffering, the pain, the sorrow, the grief, the losses that have occurred, the trauma in one's lifetime, in one's family, in one's community, but also in the lifetimes before of people's ancestors and those around them. So this is to give us a sense of when we see, when we're working with someone and we think we understand what's going on, or we have an appreciation of what the presentation is, there is so much more that's going on that we don't have a sense of, that we might imagine, but we don't have a sense of. So this is to bring to mind for all of us that there is much below the waterline. And on the next slide here, this is yet another way of depicting the similar message that as we stand as providers, as nurses, as other healthcare providers, with our tools, in this case, this is a fire extinguisher, in an attempt to treat what's going on. There is much, again, below the surface that we don't see, that we haven't felt, that we don't know, that we haven't shared with the person or the family sitting in front of us, that may need to be attended to. And that when we provide our interventions, sometimes they're talk interventions, sometimes they're pharmacotherapy interventions or referrals, that we're really only getting to a certain aspect of the presentation, and that there's more calling on us to attend to. May told us as we were running through the slides last night, a metaphor that came to mind for her, or an image that came to mind for her as we talked about this. Maybe you want to share, May?
So, you know, we come from a land where there's lots of muskeg. And if you've ever witnessed a forest fire, what you see below the forest fire is a lot of smoldering smoke. So under that muskeg is where the fire is burning, and that's the grief and the sorrow that our communities are experiencing every day. And so I don't think we've found the right fire extinguisher in our community. We have been advocating for other ways to deal with that fire that's been smoldering for so long. And hopefully, you know, I think whoever works in this area, in the area of mental health and substance use, if you don't have that hope, then you're going to move on to another place of employment. So we talk about colonization as being the source, the roots of, you know, growing up in a country like Canada where, you know, Indigenous people did not have the right to vote until 1960 and 1965 in Quebec. So if you look at how a colonized people responds to things like displacement of land and culture, so the land was taken from us, they say, through treaties, and we've never felt that we were a valuable treaty partner, that we got a fair exchange for the land that we have showed with the colonizers. We also experienced so many decades of residential schools where young people were taken away from their homes at, you know, 5 or 6 years old, and some didn't return until they were into their 30s. And you know, the fact that they didn't have those early childhood experiences with their siblings in their community, that relationship with the land, that spirituality that they need. Part of the introduction of alcohol created, again, years of you know, behaviors that I look at in addiction as being learned behaviors. And so when I work with people, I know that if you can learn something, you can also unlearn it. So the hope that we have for treating substance use and addiction is always that hope for the client. It's going to work for them. The disruption of families has been documented since the TRC was released, and the videos, and when you watch those, it's real. I mean, people have experienced all those things that you see and you read in the history books about colonization in Canada. Next slide. So our legacy, you know, we hate to say that our legacy is mental health and addiction issues. You know, our legacy should be the richness of this land and the opportunity to be able to excel in a very rich history, a very rich culture, and share the traditional and cultural medicines that we have. So the outcomes are, you know, a really high incarceration rate among men and women in Canada, particularly in Northwestern Ontario. We have higher rates of incarceration for crimes that are not even crimes of violence. I mean, they're you know, breaching parole. So they're, you know, the incarceration really doesn't have a great impact on being able to heal the wounds that our people are experiencing. Unfortunately, yes, we have a lot of people dying, both from the suicides as well as the overdoses. Right now in the urban hubs, we notice that, you know, 40% of the suicides, of the overdoses here in Thunder Bay are Indigenous people. The last picture is one of the survivors from the residential schools, and still years and years of having experienced that, still feeling the pain. We talk about First Nations mental wellness, and we strive for our patients and for our communities that they find the hope, meaning, belonging, and purpose. And that's how you will face the historical and the ongoing trauma that we're experiencing.
So this is our first polling question. The question is, what are you seeing in your communities as an impact of COVID-19? You can respond to one or more answer. A, more presentations of acute anxiety, depressions, destabilized conditions. B, higher rates of suicide attempts and suicides. C, persons presenting with alcohol or substance withdrawal. D, higher rates of drug overdoses. E, police reports of violence related to alcohol and substance use. And F, people and families using land and cultural strengths to cope. Poll open.
Poll open, votes are coming in.
Thank you. Again, you can vote for more than one if you wish.
We're at 35% of votes entered. We'll just wait a couple more seconds.
It should pop up right on your screen. And it seems that some people are saying you can only vote for one.
Yeah.
Tough choice.
Pick the most prevalent that you see.
And Sabrina, just so you're aware, they're also voting for the second question.
At the same time, or?
Yeah, and then we'll present them.
Okay. So question number 2, in case you haven't voted for that yet, is where are you providing care for Indigenous persons and communities? Urban center, rural area, remote community, hospital, community practice, nursing station, and other. Poll open. For question 1, if you wish to respond more than one answer, please put it in the chat and I will make note of that and we can discuss that with the presenters.
And we're at 75% of votes entered. So we'll just wait maybe a couple more seconds.
It may be with the unanticipated artifact that you can only vote for one when we intended to invite you to vote to name as many as you thought was applicable, that we see a higher number of the first answer as people went down the list. So we may be seeing underrepresentation of some of these other experiences that people are having.
Someone has answered all boxes.
Yeah.
So I'm going to go ahead and end the poll. And I'm going to share the results.
Yeah.
So we'll do question 1.
So this might represent the limitation of these kinds of tools, right? Just like we were depicting earlier in the image, there's only so much that we can see of what people are holding in their systems. And when we gave the image of the iceberg, same here with this question. It probably limits what we can see of what people are experiencing.
And I guess too, it depends, right, on the time and degree of contact, because in the short contact, that's what you probably see. Longer term contacts, the rest would become more visible.
Just to go through some of the chat pods, people were saying depression and anxiety. Someone said police reports of violence. There were a couple of them. High rates of violence and police involvement, and substance use as well. Addictions and child welfare calls, suicide attempts and suicidal ideation. And then an increase in relapse has been noticed in previously stable clients. Perfect. Did any of the panelists want to comment on this, or should I move to this?
It would be nice if had we been able to cross-reference it, had we had that level of sophistication to cross-reference both questions, because what you're seeing in different areas of the province and in different practice settings, of course, may vary. And we work in communities very much like you do. Those the people who are on this call, we work in very similar settings. So we share with you that these are some of the things we're seeing as well.
For the second question, urban centers was at 32%, other and rural 17 and 18% respectively, followed by remote community practice, remote community and hospital and nursing station. So we can advance to the next slide, Tanya.
Thank you. May, I think this is.
I thought this was your slide.
Sure, I can attend to this. So for all of us, whether we're in a nursing role, nurse practitioner, or a physician, or any other healthcare provider, particularly when the presenting issues are mental health and addictions, this applies to all the patients that we care for, all the clients that come into our clinics. However, I would emphasize this in caring for people with mental health and addiction issues, that rapport is the primary intervention, or the most important medicine, if you will, to offer people. And so a non-judgmental, receptive approach is very critical to being able to go any further. We are often very focused on the professional requirements of our roles, the expectations of our colleges, and certainly it's important that a history primarily, and sometimes a physical exam, be performed. However, when it comes to these presentations, without the element of rapport and really open-minded and open-hearted approaches, it will be hard to proceed. And we've all been part of interactions where the patient became very distressed, very agitated, or even resistant and combative. In retrospect, we could perhaps sit down in our quiet time afterwards and reflect on our own that it was perhaps related to our lack of emphasis on rapport. So this is familiar to many of us, and there's other people with lots of experience, even teachers out there, who probably talk about this in their roles as well. The formulation of a diagnosis is important. Lindsay Hancock will speak to some aspects of assessment and treatment of withdrawals from different substances. So without a diagnosis, it's difficult to proceed. The treatment planning, especially with these presentations, really involves very explicit communication with the patient and the family, if possible, or whoever else the support circle is, that's either there in our clinical setting or at home and on a phone. And to consider consultation if necessary, depending on your clinical setting. That may be part of a policy, or that may be part of just practice. That offering and providing the treatment intervention. And again, we'll be speaking on this webinar very specifically to withdrawal management interventions. The consideration of referral for further services depending on the case. And it's because we knew that there would be many audience members from Northern Ontario, we wanted to highlight the use of crisis lines, particularly during this time of COVID, where we all cannot seek or access face-to-face care. And Nan Hope is a crisis line that's a new intervention. The Talk for Healing is probably a little bit more familiar to people from previous experience. And May, perhaps you could comment specifically on the Nan Hope. I know it comes up in a later slide as well, but maybe you want to speak to it a little bit here.
So Nan Hope is a brand new service that was created by the Mental Health and Substance Use Working Group, which both Sharon and Lindsay and I are a part of. We've been meeting since March with NAN-wide members representing the tribal councils and communities. So early on, we noticed that we had to find a way to have people in the community to reach out for support. So this is not just a 24/7 crisis line. It is. You can also reach someone in one of the northern dialects of either Ojibwe Cree or Mishkigwak Cree. And so there's that crisis line that's available, but part of it is also a rapid access program. So when we have navigators who will get the client to a counselor, either an existing IRS counselor or someone registered with non-insured health benefits or with Dalton Associates. The Rapid Access has 150 counselors available who have the cultural competency and the experience of working with Indigenous clients. So it's available for any NAN member who resides on their home territory or in an urban place.
May, this is yours for sure.
So considerations for caring for persons with mental health and addictions issue. Again, Sharon talked about, you know, how to be non-judgmental, but we realize that sometimes you can find some difficulties and you know, quickly make judgments about people who use substances. And so that respect, so when we operationalize respect in our culture, it's again not to make judgments, not to lay blame, trying to find a comfort level with the client that they're going to give you enough information so that you can actually develop that treatment plan. A safe space for people. In some of our health centers, you know, there's not a lot of privacy. People can see who's going to the nursing station or the health center. But still you have to explain that confidentiality will be respected, that, you know, you have to abide by, again, your college's expectations and the ethics that we have. We all have internalized we all stigmatize, put it that way. And I think in some ways, recognizing what your stigma is and then trying to find a way around that you're not using or placing any stigma onto the client. Again, it's a struggle. I mean, I've been a professional nurse for, you know, many decades, and I think we have to really check who we are, what we think, and what our attitudes are. Provider safety is really important. We know that somebody had mentioned an increase in violence in our communities. You're working in the area of mental health and substance, and we know that there can be unpredictable behaviors. We know there can be aggression, and so having somebody with you, you know, close by, making sure that you're doing that quick assessment. We do have police officers in our communities. We've actually increased the number of officers and their length of stay. And so provider safety, if you're ever concerned about, you know, the potential of violence with the client, then, you know, just make other measures. When we talk about collaborative treatment planning, some of our community-based workers are the best sources of ensuring that anything that's any intervention actually applies to that client and can be carried out. I'm really thinking about young people here. We know that in some places the suicidality ideation is real. Our young people have made probably the most calls to our NAN Hope Line. They're chatting. Interestingly, 80% of our calls that are coming into the NAN Hope Line are through chat. So that just tells me there's a younger population who are reaching out. So finding, you know, the collateral information is really important. Ensuring that the client safety is taken care of, and ensuring that if there needs to be 24-hour watch with the client, if you send them home from the nursing station, that there is someone who's there to take care of them.
So motivational interviewing is, well, if you're from my age group, it's not something you were taught in your training. It's something you learn as you go. It's something you learn in our journey in life, as well as professionally. We all use motivational interviewing every day when we're trying to negotiate, persuade, or weave through something that we're trying to get or trying to do. we've all used the skills of motivational interviewing. We might not be aware that we're using these skills per se, and many people now in their training are being formally taught motivational interviewing and some of the particular tools that might be helpful. Some of the essence of these tools is listed here. Expressing empathy is authentically placed empathy and respect for the individual. Not by that we don't mean sympathy, to feel sorry for a person. That empathy allows for a respectful interchange with the individual, as well as maintaining the well-being and resilience of the provider. If we offer feeling sorry for each individual with the tremendous suffering that people come to us into the settings where we work, this can be very difficult for us as providers as well. So motivational interviewing supports the expressing of empathy, to develop discrepancy and to develop connections. So to build on the rapport, to, for instance, pose to someone, so you're saying you don't want to change, you want to keep doing what you're doing, you don't have any concerns about your alcohol use, so then I'm curious, why did you decide to come here today? If you don't want to make change and yet you're here, you are sitting with me and you haven't gotten up and walked out of the room. This is lovely. So what's going on? What's happening? It seems like there might be more going on than just the intention to not quit. It seems like there's part of you that might have an interest or be curious about this, because here you are sitting in front of me. This might be an example of developing discrepancy. To explore with the individual that you're sitting with, to look at what might be at the roots of their resistance. What is it that's making it difficult for them to contemplate change? What are their barriers? What are some of their challenges? And how could we address them and see if there might be a way to help someone? So you say that you're ready to make change, and can you tell me what might make some of that difference? And let's have a conversation about that. So depending on where someone is in the sort of the preparation for change cycle. To support self-efficacy, to recognize that our patients, their families, and their communities have strengths, far more strengths than struggles and disorders, as we refer to them in diagnostic and pathologizing nomenclature. There's a lot more strengths than there are disorders. And to support a person's emancipation to make their own decisions and to move forward, and to know that people, most people fundamentally, I'm going to suggest all people fundamentally want to live well and with wellness. And as May suggested, and as is strongly, has been strongly developed by the Thunderbird Partnership Foundation, the sense of hope, purpose, belonging, and meaning. The Thunderbird Partnership Foundation is an invaluable resource all across the country. It's a national organization that oversees mental health and addictions initiatives for Indigenous communities and programs. And if you go to their website, there is a wealth of tools. And one of them is this motivational interviewing toolkit. So there are other ways to learn or develop your skills in motivational interviewing, but in terms of one that has a lot of Indigenous ways of knowing, from the TPF, the Motivational Interviewing Toolkit might be of assistance to you. No matter if you have lots of training in this area or a little bit, or have never heard of the term motivational interviewing, this would be a great resource to turn towards. I think it's exciting to work with people who dig their heels in and say, that's it, I don't want to make change. That then it causes this excitement inside of me. That's my experience as a provider, to say, so what do I do? What are my tools? Where do I go? How do I maneuver here? How do I find a way to engage with this person that might just even create just a little smidge of curiosity for change? And that's why motivational interviewing excites me and can be a really helpful tool.
So if you go back to the smoldering fire, the smoldering muskeg fire, and I mentioned that there was a framework, the First Nations Mental Wellness Continuum Framework. So from our perspective, we interchange. We've actually don't use the word recovery. We talk about wellness, and it's an individual, family, and community wellness. But this is the framework that's going to help us put out that smoldering muskeg fire. It's a national developed tool for us that recognizes our culture, our land, the things that are sacred, our language, our children, and all the things in our community that we want to start addressing to, again, bring that degree of wellness.
Hi everyone, here's our next polling question. What are you using in your clinical setting to guide the assessment and treatment of withdrawal? You can answer more than one multiple choice question. I've been told that works this time. A is Siwa or shot for alcohol withdrawal. B is the COWS or SLFNHA scale for opioid withdrawal. C is some other assessment scale. D is what are these scales? I've never heard of them. E, I've heard of those scales but can never find them when I need them, or I just don't find them useful. F is ISC clinical practice guidelines for nurses in primary care. G, other clinical guidelines or resources either locally or online. H, honestly, I just wing it. I consult a colleague. Or J, consult a physician or another consultant remotely. And polls are open.
I just want to state for the record that as a rural family doctor, I spend most of my professional life winging it to some extent. So there is no negative connotation implied in that answer. It's probably the one that I would choose if I were answering this question.
Votes are coming in. We'll just give it a couple more seconds. All right, I'm going to go ahead and end the poll, and I'm going to share the results.
So Lindsay, most of people use the Siwa or shot, followed by the COWS or SLFNHA. But 22% has never heard of these scales. Stay tuned, there's some fun in the next couple of slides. Consultation with a colleague and or a family physician, and then using other practice guidelines.
All right. If you have a particular clinical guideline or resource that you really love, put it in the chat. I'd love to hear what other people are using. Okay.
So CYB. One of the questions earlier had mentioned the GAIN.
Yeah, the GAIN short screener is a screening tool for mental health and other stressors, and a little less specific to the clinical setting of assessing withdrawal. It's a great tool. Thanks for bringing it up.
So,
yeah.
Is it okay for me to proceed? So I want to introduce you to the nursing resource for withdrawal management that Sharon and I wrote. But first I want to just explain that this resource was created for a very specific clinical context, which is nurses working in remote Indigenous communities during a pandemic. So the backstory here is that May co-leads, and Sharon and I both sit on this NAN mental health and substance use working group, which is part of NAN's COVID response. And one thing that came up fairly early in the pandemic on our phone calls was people were really worried that the lockdowns due to the pandemic would result in people's usual supply chains for drugs and alcohol being disrupted. So we're quite concerned that people, particularly in the remote fly-in communities, might end up going into involuntary withdrawal in large numbers. Then we started imagining this nightmare scenario where there were dozens of people going into withdrawal all at once, plus there might be a COVID outbreak in the community. Keep in mind that in most of these remote communities, the nursing station is the only healthcare facility available. So we were asked to provide some expert opinion on how nurses might be able to manage withdrawal during a pandemic, including some suggestions for remote assessment and maybe even remote treatment if necessary. So this resource is not what I would call a best practice guideline. It is more of a making the best of a difficult situation guideline. The medications that we recommend are also based on our experience, informed by evidence, but also influenced by just which medications we know are available in the nursing stations. So having said all that, I do think that the resource does contain information that might be more broadly useful for a range of providers and clinical contexts, which is why we offered to make them available to a larger audience. So I'm not actually going to review the resource in any great detail because we don't have time. The document that has all 3 guidelines in it is 15 pages long because brevity is not one of my strengths. So I'm just going to talk to you about the document, and it will be provided to all of the participants in the webinar after we finish. So there's 3 guidelines, one each for alcohol, opioid, and stimulant withdrawal. There's a little bit of repetition, particularly in the assessment sections, because some of the questions that you ask people are similar or the same. The structure of each guideline is that it starts with a general introduction to the withdrawal syndrome, and then it proceeds to a telephone triage section. This one is a bit context specific because it's really meant to help an on-call nurse up north decide whether a patient needs to be brought in for an in-person assessment. But I think the information would probably also be useful for nurses in emerge departments doing triage, or particularly in rural emerge departments where the physician might not be on site at all times, to guide your decision about whether the physician should be called in to come right away to assess the patient. Next is the assessment session, basically history, physical exam, medical history, or information from the chart. This is designed for an on-call nurse who needs to do a thorough assessment and then call a physician to review the case and get orders, because that's the system that Sharon and I are both used to working within. So the goal in this situation is for the nurse to collect all the necessary information the first go around, so they don't have to get sent back to the patient to ask more questions. So I tried to be fairly comprehensive in the assessment section of the guideline, which I think would be probably helpful to anyone that is needing to do an assessment on someone that's in withdrawal, particularly if it's something you don't do all the time, just to help you kind of organize your thinking around it. So next is in-person medical management, which I think is pretty similar to what would happen in an emergency department. Obviously, it's sort of designed for a nursing station. The main difference would be that the lab recommendations are a bit context specific, because in our communities, there's just a few lab tests that we can get done in the nursing station using an iStat machine, and the rest are sent out to Sioux Lookout for processing, and we would expect to get the results in 1 to 2 days, so not soon enough to guide care acutely. So what you might do if you're in a hospital and can get your lab results right away might be different. And finally, there's a section on outpatient medical management, which is very COVID specific. So in a situation where you're trying to keep patient traffic in and out of the nursing station to a minimum, maybe you've got a COVID suspect patient in the nursing station waiting for transfer and you're trying to prevent contact with other individuals, which patients might be appropriate for treatment at home with kind of supervision by phone. And if we were to do that, how might we do it as safely as possible? So I know that home detox and outpatient withdrawal are things that are discussed in other contexts, and particularly in kind of the addictions world, but I don't know how transferable our recommendations might be. Along with our nursing resource that we created, we have some additional resources to go along with it. So the guidelines actually recommend the use of these 3 scales, SIWA and SHOT for alcohol withdrawal and COWS for opioid withdrawal. So I'd like to include them with the guidelines to make it easier. And there are also some resources that were created by Indigenous Services Canada for their nurses. Upon reviewing the guidelines, they created these resources. So there's a couple of discharge information and medication logs for patients that might be going home with medication to take, and also a clinical support tool that kind of summarizes the guidelines. So I'm going to talk briefly about the 3 different withdrawal syndromes, and this is not going to be comprehensive in any way. So the thing that I want you to know about alcohol withdrawal is that this is the one that can kill you. So severe alcohol withdrawal can develop into delirium tremens, or DTs, which can be life-threatening if not treated. So it's really important that we take alcohol withdrawal seriously and treat it to prevent more serious complications. I would point out that people sometimes use the term DTs a bit colloquially to describe any kind of severe withdrawal. So if someone comes in to your emergency department and their last drink was 10 hours ago and they're like, oh my God, I feel awful, I'm going into DTs, like that's not the case. True delirium tremens is a bit of a late finding in withdrawal, onset anywhere from 2 to 7 days after their last drink. And it's characterized by a truly altered mental status, so severe confusion, as well as abnormal vital signs, things like fever, hypertension, tachycardia, and hemodynamic instability. So alcohol withdrawal is pretty easy to treat. You basically just keep giving benzos until they feel better. We recommend a symptom-guided approach. So this is where you administer a scale, one of these 2, and if they score above a certain number, you give a dose of diazepam. And then you repeat that every hour or whatever time interval makes sense, and you just keep giving them more until they consistently score below that number. Don't be surprised or too alarmed if you find yourself giving what seems like a terrifyingly high quantity of diazepam or lorazepam. People who drink a lot of alcohol have very high tolerance to alcohol and a similarly high tolerance to benzos. So a dose that would be fatal in someone who doesn't drink alcohol would be completely reasonable in someone who drinks a lot. So opioid withdrawal. Unlike alcohol withdrawal, opioid withdrawal is not inherently life-threatening, but it is extremely unpleasant, and patients will sometimes tell you they feel like they're going to die. And there are some secondary health risks. So mostly if you have prolonged vomiting and diarrhea, you can become dehydrated or develop an electrolyte disturbance. Also, when people are in withdrawal, they're very uncomfortable and having such strong cravings that they will often find themselves doing very ill-advised things in an attempt to feel better. So treating the withdrawal reduces the risks of those risky behaviors as well. Buprenorphine naloxone, better known as Suboxone, is a sublingual opioid that we use for chronic treatment of opioid use disorder. So like methadone, it's taken once a day in a stable dose to prevent withdrawal symptoms and cravings when someone is in recovery. However, it is also very useful for the acute treatment of withdrawal. So even if someone is not ready for long-term treatment, you can still give them Suboxone acutely to manage their symptoms, at least in the short term, and maybe that gets them into a better place physically and mentally to think about longer-term options. If buprenorphine is unavailable or contraindicated, there is the usual cocktail of symptom management medications. So you can give them Gravol for the nausea, Imodium for the diarrhea, Clonidine for the shakes and chills, Trazodone for insomnia. These are better than nothing, but not as good as just giving them Suboxone. So the most important thing to know about opioid withdrawal is that people lose their tolerance to opioids very quickly. So what we see is that when a person is off opioids for any reason, either on purpose or involuntarily, for a period of days to weeks, and then say they relapse or they start using again, if they take what was previously a normal dose for them, they can overdose and die because they've lost their tolerance. So it's really important to educate people about overdose prevention, which is make sure you have an naloxone kit and know how to use it. Make sure you're using with someone else around so they can keep an eye on you and give you the naloxone if you need it. You can't really give naloxone to yourself if you're unconscious. And we tell people, don't go straight to your usual dose and take it all at once the way you might have done before when you were using regularly. If you're relapsing, take just a little bit, see how it feels, see how strong it is, whatever you just bought. And then gradually increase till you get your desired effect. You can always take more. You can't untake it once you've taken it. So we try to provide people with just practical information about how to not die if they relapse. Stimulant withdrawal. So similarly, this is also not inherently life-threatening, but definitely can still pose health risks. Specifically, stimulant intoxication and withdrawal can both cause quite severe agitation, anxiety, paranoia, or even frank psychosis. And this altered mental state can definitely make people a risk to themselves or others. Unlike with alcohol and opioids, we don't really have any good pharmacologic treatment for stimulant withdrawal. There's no medication we can give the patient to just make them feel normal. So when people are trying to quit, the treatment is mostly non-pharmacologic. It's lots of kind of behavioral, psychological, and social support. However, in the acute setting, we sometimes find ourselves needing to use either oral or intramuscular benzodiazepines and antipsychotics just to help people to de-escalate and to stay safe. I would say that the non-pharmacologic stuff is also extremely important in the acute setting. So when somebody's in a very activated state, we want to use our speech and behavior and the environment to help them self-regulate as much as possible. So sort of approaching people with a very calm attitude of acceptance and reassurance, but also trying to keep them in a place that's quiet and not too brightly lit, and basically to just do whatever seems reasonable under the circumstances to keep them safe and to help them de-escalate themselves. So the last thing that I wanted to say is just remember that people can have more than one problem at a time, and don't get so focused on the withdrawal that you forget the bigger picture. So sepsis and other severe infections can present with signs and symptoms that are very similar to withdrawal. If you do this for long enough, you'll probably find yourself at some point treating someone's sepsis with diazepam, and it's embarrassing when it happens, so we try not to do that. It's always prudent to ask people if they're using needles to inject any drugs. Even if the person's there talking to you about their alcohol withdrawal, you can still ask them if they're using needles. And if so, are they sharing needles or equipment, or are they reusing their own needles? So these behaviors pose different risks. Sharing needles or equipment with other people increases the risk of bloodborne infections like Hep C and HIV. Reusing your own needles increases the risk of bacteremia and other severe bacterial infections. So it's really important that we tell people about this and talk to them about harm reduction. Let them know where they can access clean needles and supplies. Encourage them to use those things. I also want to just cycle back to our iceberg metaphor from earlier and remind you that most people struggling with addictions also have some underlying mental health and or social concerns that are driving them to seek relief from their suffering in this way that's not serving them. So if you're going to tell someone that they should be changing or stopping their substance use for health reasons, it can be helpful to ask about and try to address some of the underlying issues. So can they be referred to a mental health professional or social services to help them get to a place in their life where they have more options and can make better choices? So that's the end of our discussion on medical management of withdrawal. We're basically just touching the surface of it, obviously. But the last thing that we wanted to talk about tonight is the other big substance-related harm, which is overdose. So during the pandemic, we've seen in some areas, especially urban centers, increased substance use and increases in overdose, including fatalities. So we're going to go back to Sharon so she can talk about this.
Thank you, Lindsay. That was helpful. And I know that the documents that are going to be sent to people to use in their clinical settings are going to be helpful. So overdose is on everybody's mind, opioid overdoses. And certainly there are other substances that are also culprits, but the opioid overdoses are most on our mind these days. And we know that this evolved over time and years ago. For those of you who have been in the business in the front lines providing clinical care or even working in policy and education, you're aware that much of this evolved over time from a market that was decades ago primarily illicit substances. So 15 years ago, when I started working with people with opiate use disorders who were seeking treatment, 9 out of 10 people who walked in the office were people who were using primarily heroin. Over time and in the last 10 years, that evolved to people who were using primarily prescription opioids that were coming primarily from a physician's prescription pad and then a pharmacy. And we see this up in the upper left-hand corner. At this time in 2015, 2016, just great numbers of people who had access to opioid prescriptions. What's happened over the past number of years, as we're all aware, because it's in our media all the time, as well as in our lives, in many of our lives, both professionally and personally, is that it's transitioned to a very, very toxic supply out in the illicit supply, which is started to transition to fentanyl being mixed into heroin or in fact pressed into pills, to now it's almost just a full supply of fentanyl. I seldom see heroin in people's urine drug screens anymore. And it's supplies that have anywhere between 10 and 25 compounds in them. So many fentanyl and fentanyl analogs, many benzodiazepines. I'm sure that there's people who work in urban settings here on the call, some of whom work in street front programs, and probably who have provided a lot more service and care, particularly opioid overdose resuscitation than I have. And they're very well aware that there's also a significant number of benzodiazepine adulterants in the supply right now. Particularly in Toronto, what we see is a benzodiazepine called etizolam that's in the supply and really affecting the overdose deaths as well. In Thunder Bay, where there's one of the highest per capita, or the highest per capita in any urban center in Ontario of overdose deaths, the discussion around the pink and purple supply that's out there right now. This is mostly overdose deaths are affecting primarily young people in their 20s, primarily men, but not exclusively. Fentanyl is the most common substance of overdose associated with overdose. Pay particular attention to those who are just being released from provincial and federal facilities. I'm talking about jails and penitentiaries. This is the group that it's at the highest risk of overdose and death, is people who have lost their tolerance to opioids because they may not have had access to zero in jail, but a much lower amount than they would have had access to on the street, and they've lost their tolerance. Then they reintroduce opioids when they're, in some cases, when they're back on the street, and they're at much greater risk for overdose and death. So these are some of the populations we want to be really concerned about. In the northern communities that we work in the remote communities, there is just now, in the past several months, an awareness of fentanyl in the urine drug screen samples that we're seeing in the community-based opiate substitution programs. And there have been 1 or 2 opioid-related morbidities, but also 1 mortality in the northern remote communities. It is not as significant as in the urban centers, but it's something we must be very, very vigilant about. So this is some of the epidemiology of the overdose crisis, much of which we're all kept abreast of and is top of mind again, not just in our work lives, but because we see it in the media every day. Just going to the next slide. What's very relevant is prevention. Someone asking a question on the chat box about naloxone. By now, I think every single one of us knows what naloxone is, not just in our clinical settings where we give it intravenously, but also out on the street and in our communities. And the many users in the population, people who are using opioids, are very familiar with identifying opioid overdose. They carry naloxone kits themselves. They know to not use alone, and they know how to inject naloxone or give the nasal spray and to resuscitate. They're very familiar, more so than us, that it takes 5, 6, 7 vials sometimes to resuscitate someone, and to how to respond and to get a person into care. So making sure that the clients that you work with, the patients that you care for, have access to naloxone if they are an opioid user, or if anybody in their family or their household is an opioid user, is super important. In the remote communities where we work, there is some supply that has been brought into the communities and distributed, but I always encourage the patients that I work with that if they're going into Thunder Bay or out to Kenora or out to Winnipeg for medical treatment or recreational purposes or family reasons, to make sure that they go to a pharmacy and to ask for naloxone. Most of these communities do not have their own pharmacy, and so they do not have the same level of governance over their own ability to access naloxone kits. So we certainly encourage them to do that when they go into town. This may apply to a lot of other settings. If you're from an urban setting, there's naloxone available in many other places other than just pharmacies. It's also, there's a lot of emergency departments that hand them out, public health departments, drop-ins, vans, safe injection sites, etc. The other level of prevention, if we go to the next slide, is at the bottom is the gold standard of treatment for opioid use disorders, which is opiate substitution treatment, which is a harm reduction modality. On the bottom right-hand corner, you're seeing the bottles of liquid methadone, which has been used for multiple decades as a treatment for opioid use disorder, and more recently is buprenorphine. The proprietary name is Suboxone. And this is an intervention that's been in use for the last 10 years minimum as modalities to treat opioid use disorders. These are longer acting opioids that physiologically settle the person's system so that they're not going through withdrawal, not experiencing cravings. That's the ideal if we have someone at the appropriate dose, and therefore may give them an opportunity to work towards a goal of reduction or possibly even abstinence from opioids. More recently, we've seen other interventions for individuals who continue to consume illicit opioids by purchase from the street. There is safe consumption sites or safe injection sites, SISs as they're referred to, in many urban centers, including Toronto and Thunder Bay. And more recently, really in the past year and only in the past month and a half, recognized by the federal government for further support and funding, is the safe supply programs, where some physicians are prescribing hydromorphone tablets. So I just want to speak to that. In this image that you have, you see both tablets and a syringe with an opioid substance. In Ontario, hydromorphone tablets are covered by ODB, the Ontario Drug Benefit Plan. So if you're receiving your coverage of your medication costs through welfare or ODSP, the tablets are funded. The liquid hydromorphone is not funded. NIHB does in fact fund the liquid hydromorphone, so the injectable formulation of a safe supply program is possible for Indigenous persons covered by NIHB. The cost coverage is not covered for people on ODB unless if they choose to pay for it out of pocket. Therefore, what's happening in these safer supply programs is they are prescribed hydromorphone tablets, which they pick up at the pharmacy and take home. And many choose, or in fact, in some of these programs are instructed to crush and inject This poses certain medical issues that we should all be aware of in case we're taking care of patients or individuals who are on these programs. So just to let you know that some of these programs exist in Toronto, in Ottawa, and in London, Ontario. And you may have patients or clients that are attending to some of these programs, and some of you may in fact work in these programs. So these are some of the prevention options that exist right now. There are rapid access addiction medicine clinics in many communities in Ontario for people to get same day access to treatment with some of the opiate substitution treatment options. But the rapid access addiction medicine clinics actually attend to people also with alcohol and other substance use issues. If we go to the next slide, of course, what many of you are familiar with is if you work in a hospital setting, you're very familiar, particularly in emergency department settings, with treating opioid overdoses with naloxone. If you're a first responder out in the community, you're familiar with some of these scenes. Some of you may be working in, again, as I say, safe injection sites where you may also be familiar with these scenes. And what we notice in Toronto, I'm going to speak to where I'm sitting today. I work in Northwestern Ontario, but I also work in Toronto. That often because of the fentanyl and the analogs of fentanyl that are in the toxic supply right now, often it takes multiple doses of naloxone to resuscitate a person. And what we're finding in the last 6 months to a year is that sometimes the naloxone is not adequate, that people remain significantly sedated because of the benzodiazepines that are cut into the supply as well. I saw a little bit of the chat box as I was walking through these slides. Etizolam, I saw someone write it in the chat box. It is something that has been found in many of the supplies. In Toronto, there are a few settings where people can have their supply tested. And so not just the urine drug screen results, but the actual product that they're purchasing off the street can be tested in some of these settings. And this is what's being seen. So this is a significant issue as well. I see in the patients that I serve that they have significant benzodiazepine effects in terms of intoxication with benzodiazepines, quite dulling of their cognitive functioning, as well as people who are having some significant benzodiazepine withdrawal symptoms when they're stopping their use of fentanyl. So not just opioid withdrawal, but a mixed picture of opioid and benzodiazepine withdrawal. There's a lot of people in this audience who have a lot of expertise in this area, who have a lot of experience, and we may be hearing from them in the question period, and they may in fact be chatting also. I haven't been able to keep up with all of the chats, but I'll take a look at them. And so I think this was the last slide that we had on some of the opioid overdose, and I hand it over to May at this point.
Thank you, Sharon. So I think to end this webinar, we were just hoping that, again, the understanding around, going, I think it's the integration of mainstream approaches with dealing with withdrawal, dealing with substance use, dealing with, the pain that people bring to you as a caregiver, and that we see the holistic approach to the clients that we have in the Indigenous community, whether they're urban or in our communities. And we know that the resources are available. So when someone asked the question about, why are we using mainstream tools? I mean, those tools have been proven for a medical condition like withdrawal. And so they're easy to apply even in a setting that's remote. It'll guide your care. So if you see somebody's COWS score quite high, that will sort of guide you on the kind of management that you do. So the integration of Indigenous knowledge and with mainstream modalities, I think, is one of the goals that we have, and that we certainly respect both streams of interventions. So thank you everyone for listening tonight.
I just wanted to attend to a question that I read in the chat box. So etizolam is one of the benzodiazepines that's been identified in the supply, the opioid supply, what everybody refers to as fentanyl or purple or pink. You know, sometimes people are just referencing it by the color. So this is one of the benzodiazepines that we see. I've certainly seen other benzodiazepines in people's urine drug screens from using this supply, but this is a more recent phenomena. And someone was asking if it takes 6 to 7 doses of naloxone, how do the Narcan kits help? They help by using multiple of them. So just as you would use multiple vials in the emergency department setting, people are using multiple kits to assist resuscitating their friends and their loved ones. And I think if benzos like etizolam are being found, is there any discussion in using flumazenil during an overdose resuscitation as well as Narcan? So this is a great question. As naloxone or Narcan is to opioid reversal, flumazenil is to benzodiazepine. There are some concerns, clinical concerns with using flumazenil, depending on how long the person has been dependent on benzodiazepines. Reversing with flumazenil can lead to seizures, withdrawal-related seizures. So depending on the setting that you're in, that could be particularly concerning. So at this point, the treatment is mostly supportive. I would imagine there are some times in some clinical presentations where flumazenil would be helpful, but at this point, it's not being used out on the street. This is an ever-evolving scenario as the persons who create and distribute these toxic substances adapt their distribution lines. The people who treat the overdoses and the effects of all of this have ever-evolving approaches. So at this point, it's not a standard to use flumazenil, and certainly not on the street in street resuscitations.
Sharon, there's another question on how many doses or vials are in one naloxone kit?
So I think pretty standardly there's 2 that I've seen in the kits that we distribute that I'm familiar with.
Fantastic. While we're on the topic of your section of the webinar, maybe I'll just keep going with some of the questions for you. In the Safer Supply program, can you talk a little bit more? Are drugs dispensed daily, or do patients get carries?
So this is a huge discussion. It's really provider and client dependent. I have patients who are on the Safer Supply program that I'm not prescribing, but that are in another program that are receiving daily dispensing of up to 30 tablets of 8 milligram hydromorphone a day. I also have some that receive take-home doses. So daily dispense of take-home doses, or also multiple day dispensing of take-home doses.
Just to further that thought, I don't know, Lindsay, if you have any comments, but are there differentiation of when you might give a patient carries versus when you might have them come in daily that might help here?
I think any of us could answer that question. I mean, I don't prescribe a hydromorphone as part of the Safer Supply, but I do prescribe Suboxone, and I would agree with Sharon that it's very sort of dependent on the patient and the situation. So, and actually in our northern communities, it's also dependent on the policies of the community Suboxone program. The Suboxone programs in our northern communities are all run by the communities. They're not managed by the doctors or by Health Canada. And so some communities are very strict and don't want people to have carries, and other places are more liberal with them. I think as a general rule, we want people to be reasonably stable in their opioid use disorder before giving them carries. So you would want them to have been on a stable dose for a little while, to not be showing signs of other opioids or other substances in their urine. And we do, of course, want to make sure that they have some way of safely storing their medication at home. And so we always talk to people about, you know, do they have a lockbox or some place where they can put it, where other people and especially children can't get at it, because, you know, Suboxone is a very safe medication, but it certainly can be harmful, especially to children, if they were to just sort of grab a Suboxone tablet off the countertop and stick it in their mouth, and it dissolves, you know, fairly quickly, and it's a massive dose for such a tiny little person. So the main criteria is kind of stability with respect to treatment and an ability to do so in a way that's safe. Sharon or May, did you have comments?
So in the work that I do, so nurse practitioners have been able to prescribe control drugs since April of 2017. But I've been working in Suboxone programs now since 2011, mainly with the physicians that work in the Sioux area. So we rolled out a program in some of the earlier communities called low dose short term. We realized that the short term, we haven't been able to achieve that just because there hasn't been a lot of counseling or support programs. I think it's getting better with family wellness teams and Choose Life and Jordan's Principles programs, because they're family oriented programs for wellness. So I do pretty low dose. So for me to give 14 days of somebody with on 4 milligrams, that's to me not a difficult thing to do. And we're able to give longer carries now during COVID-19. You know, I look at sort of the dosage. If it's a 16, then I probably go to 7 days if they have access to a pharmacy. In the programs that are in the communities that I work in, the health directors who run these programs, so I do the clinical part for them. They do the administration of the medication through community-based workers, and they've now taken a twice-a-week approach to administering the medication. Partly is, again, the social distancing, but I think it's also people in their community. You can tell when they've relapsed. You can see the behavior changes. They see them every day, and I'm confident that, you know, the clients are still stable and doing well.
Fantastic, thank you. There is a question from Edna. Can you please discuss any paramedic changes in response to COVID and the impact this may have on overdoses? I suppose it depends on which community you're from.
Yeah, Sharon, do you have more up-to-date information? I remember
Sorry,
this being.
Can you say it one more time, what we're responding to? Sorry,
Sure, yeah, the question was, can you please discuss any paramedic changes in responses due to COVID and the impact these may have on overdoses?
Oh, okay. So at the beginning, there was some worries and concerns about aerosolization and the use of the nasal naloxone kits, the nasal spray delivered. I think many people have learned to adapt as first responders, particularly in the safe injection sites. And there's, you know, it's a matter of moving the head of the individual, like so that it turns away, so that as it's being sprayed, it's not creating aerosolization directly into the face of the responder. So at this point, people are emphasizing the need to intervene and to provide support for overdose, and just creating adaptations so that they're not concerned about aerosolization.
There's a question from someone talking about traditional medicine use with alcohol withdrawal in a traditional plant. So I've been working with an alcohol detox program that's initiated by the community. So they've been a period of detox where we use the medication, the you know, the Valium, the other benzos to get people through the first 3 days of acute withdrawal. And now they're gone off to a land-based camp where they're using traditional approaches. One is medicines that you get from the land. Again, until we see the plant that you're specifically talking about, we use the plants in our area called Wike It's a root that you find in the riverbank, and it takes care of some of the aches that you have. And they also use Labrador tea to make, and cedar tea to drink to deal with any of the hydration issues. So our community members have learned to just over time to be able to trust in the medicine, but it's also the spirituality around using land medicine and the significance of Mother Earth to be a healing element. So I like that question about the plant. I think the plants are indigenous to certain areas. So what we have in Northwestern Ontario may not be available. For instance, we don't have sumac in Northwestern Ontario, and it's a medication or a plant that's used in Northeastern Ontario in some of the remedies that they have for that particular one for diabetes.
In follow-up to that question, I know there were a couple of questions about traditional holistic approaches and using Eurocentric tools, and I know you've done a really great job in answering that question. But I was reflecting on one of our discussions that we had in preparation for this webinar, and I was wondering if you could elaborate how in your current practice do you use either these tools or scales or approaches using a traditional holistic approach. I know it's probably another webinar in and of itself, but I didn't know if you had any tips or tricks that we could, or lessons that we can learn from you.
You know, I think we've all learned some of what our gifts are, and we all have inherent gifts. I mean, part of that is to be able to build a rapport, to be able to trust openly our clients who come and ask us for care. But I also think that, you know, the Creator has given us, you know, some of the what we call the 7 gifts of the Creator. One is courage. I know that I was gifted over time with, and I don't know if this is a value that you learn as you get older, but certainly I'm much more, I use that gift of courage more when I'm working in a what I would call a holistic team, where I have traditional knowledge keepers, counselors, social workers, community-based workers. So we, with our combined knowledge of the communities and the culture, we're able to successfully provide care with really good outcomes.
Oh, May, thank you so much. That is just a perfect note, I think, on which to end I call it a seminar. I really feel this has been like a seminar. Our time is up, and I want to thank everyone for participating. And I really want to share on behalf of everyone here, special thanks to Nurse Practitioner May Catt, to Dr. Sharon Cerrone, and Dr. Lindsay Hancock. You've done such a beautiful job of presenting an integrated, seamless session tonight. And it has had a wealth of information for us all. Very non-threatening approach. I think you've given us all that courage that you've talked about, May, to go out and do our best work in working with our clients. The last point I would say is this was very meaningful, and that you shared so much of your personal experiences and stories in your work. So thank you all very much. Now, for all of you listening in and taking part in this, I want to thank you for your questions and let you know that you will receive a link to an evaluation for tonight's webinar. We ask you to please fill it out, as the survey does assist us greatly in evaluating this webinar and helps us to plan for future webinars. And upon completion of the evaluation, you will get a reward. A link will be provided in which you can access a certificate of completion for your continuing education and professional development profile. Now, the evaluation closes within a 2-week period, So I would say don't waste time. Usually it's best to do it right after when everything's fresh in your mind. And should you require the certificate and otherwise, please ensure you complete the form within 2 weeks of today's date. And we do hope you'll join us for other webinars. And to find out more about other programs that we have, please check the RNAO website and keep in touch with emails that may be coming your way as a participant in this webinar. So on that note, again, I want to thank our speakers and of course Sabrina and Tanya for making sure that all the details of this webinar have been worked out. Thank you all and good night.